Hi everyone, my name is Fanendra Antaram. I'm a cardiology fellow at Ascension Providence Hospital in Southfield, Michigan. I'm going to be presenting about a type A aortic dissection that was diagnosed on transthoracic echocardiogram in the clinic today. I do not have any financial disclosures. Type A aortic dissection is a catastrophic diagnosis and its presentation can be quite elusive. It requires a high degree of clinical suspicion for prompt diagnosis and management, as it has high mortality despite treatment. We present here a case where transthoracic echocardiography aided in the diagnosis of a type A dissection in the clinic in the outpatient setting, despite its low sensitivity. A 66-year-old Caucasian male presented to the cardiology clinic for routine follow-up of his coronary artery disease. He reported having one episode of chest pain that lasted about 30 seconds and resolved with isosorbate dinitrate, which was his old medication. The pain was associated with headache and palpitations and also radiated to his jaw. In addition to his heart disease, he also has history of hypertension, hyperlipidemia, and binge alcohol use disorder. He was hypertensive at presentation with 160/70 blood pressures in both upper arms. Heart rate was in 70s. A TE was done in the clinic, which showed normal EF of 60%, no valvular abnormalities. However, had dilated ascending aorta, and there was concern for dissection along with the false lumen and thrombus. Following this, he was emergently transferred to the ER on an ESMAL drip for urgent surgical management along with medical management. A CTA was done in the ER, which showed and confirmed the fusiform aneurysmal dilatation in the ascending aorta with intimal tears extending into the ostium of the left common carotid along with the intramural hematoma. CTA surgery was consulted and repair of dissection was done with replacement and evacuation of hematoma and confirmation of imaging findings. Aortic dissection is defined as separation of layers of aortic wall due to intimal tear. This may occur spontaneously, secondary to trauma, iatrogenic injury such as cardiac catheterization, or penetrating aortic ulcer. Young age at presentation may be associated with history of connective tissue disorders such as Marfan and Ehlers-Danlos syndrome. Incidence may vary depending on population sample from 2.6 to 12.4. And the diagnosis is associated with high mortality and increases up to about 44% despite intervention, and is sometimes diagnosed post-mortem due to its elusive symptomatology. Stanford classification is commonly used and is described into type A and type B, with type A involving ascending aorta and type B involving the part of aorta distal to left subclavian artery. As mentioned before, diagnosis requires high clinical suspicion with characteristic symptoms of chest pain, pulse deficit, and or difference of systolic blood pressure more than 20 millimeters of mercury in both upper arms. Although TEE and MRI reach up to 100% sensitivity, transthoracic echo can be sensitive up to 94.7% in type A aortic dissection, but not in type B, and can provide quick information as described in outpatient. In conclusion, transthoracic echo can provide enough information for a diagnosis of type A aortic dissection, especially in an outpatient population, and we propose that it should be part of the diagnostic panel of a type A aortic dissection due to its ease of access, portability, and to also improve operative diagnostic accuracy in case of future events. Thank you.